Well, hello everyone, and thank you very much for the opportunity for us to present to you today. We're presenting on the Discovery model, which is a co-designed model of care where we've worked with people who have long COVID. I'm going to begin by acknowledging the traditional owners of the country on which we work and learn, the Wadawurrung, Bunurong, Boonwurrung and Wurundjeri Woi-wurrung people of the Kulin Nation. We recognise their continuing connection to land, waters and culture, and we pay our respects to their elders, past, present and emerging. So I'm speaking to you today as a representative of the Western Health COVID-19 Recovery Collaboration, and here are some of my collaborators. So we're a multidisciplinary group, including people from medicine, nursing and allied health. And we work across 4 different institutions. So primarily at Western Health, which is a public health service in the western suburbs of Melbourne. But we also have collaborators from Deakin University, University of Melbourne, and the National Ageing Research Institute, or NARI. So just as a brief introduction to long COVID, it's something I'm sure we've all become unfortunately familiar with, but we do know that most people make a really good and full recovery from COVID, but there are a fairly significant proportion of people for whom there's a very long tail to the infection of COVID, and they have really sustained symptoms going over many months and going into years now. So the World Health Organization has called this post-acute COVID condition, or PAC. It's also known as a few other names too. We tend to use the word long COVID because that's the name that consumers come up with themselves. And from the case description that the WHO has given us, they're talking about symptoms that are still recurring 3 months after the onset of a COVID infection. And these symptoms may be new symptoms, they may be an exacerbation of a condition that somebody already had, or they may fluctuate or relapse over time. So it's not a diagnostic criteria, but we do have this case description, which I think most people are working from around the world. So our project really set forward to come up with a co-produced model of care. In other words, a model of care that was designed with people who have lived experience of recovering from COVID, and particularly people who've had delayed recoveries from COVID. So the pandemic itself has made co-production even more challenging than it was before, but it's even more crucial now that we work with consumers and carers and anyone else who's using our services to come up with the best services that meet their needs. Without including consumers and carers in the design of health services, you can end up with services that just aren't relevant or don't work very well. So we have to get back into the habit of including consumers and carers like we were before the pandemic. We did receive some grant funding, a very small grant, to co-produce the model of care, but also some resources to support the model of care. And the resources were intended for the healthcare workers, but also for the patients and carers, so that everybody had access to what they needed to help with recovery. The process that we undertook was founded on the principles of evidence-based co-design, so EBCD. But we did need to abbreviate the process. We were right in the middle of our 3rd wave at that point in Australia. We're the opposite seasons to everyone else, so our winters run over the middle of the year. So we weren't able to do a full and detailed EBCD process because we were under the pump as well with lots of all our additional cases that we had. So we've used an abbreviated approach, but we acknowledge that ideally you would spend more time on this process than we were able to. This is just a brief overview of our process. So our process included studies that we had already undertaken in the year prior to the development of the model of care. And it was really seeking to leverage the information we already had from that research. So step 1 was identifying our stakeholders. That included mostly people within Western Health, but we also do have some collaborators from outside, as I mentioned before, and the lived experience experts, which is what we were calling our patients and carers. So step 2, we've done a longitudinal study, which is ongoing, where we're surveying people every 3 months after their COVID infection, and that's mainly based around the HUDAS as a measure of function. And it's now up to about 90 narrative interviews where we've simply asked people, tell us your story of COVID and what's your recovery been like. So they're very unstructured interviews. In step 3, we also collected data from other stakeholders. So that was healthcare workers, allied health, medicine and nursing. And we were asking them, what do you know about long COVID? What do you want to know about long COVID? And what resources do you want available? In step 4, we drafted a patient-rated outcome measure, which is part of the resources we developed in this project. And we've also been doing an integrative review of all of the rapidly expanding evidence that's happening around the world. Australia doesn't have a lot of evidence base at the moment because our cases, thankfully, have been smaller than most countries. But as you would know, there's probably 100 new studies coming out every day at the moment. And step 5 is what the process we went through to actually design the model of care and the resources, which we'll take you through now. So the discovery model of care, so it's evidence informed. We chose not to say it was evidence based because the evidence is still only just developing, but it's evidence informed, but it's definitely person centered. So we came up with a blended model with the consumers. Telehealth and telerehabilitation has come into the fore over the past couple of years, and it works really well for a lot of people, but it also doesn't work so well for others. So there is a choice in the model between receiving face-to-face care or telehealth care, if that's going to work better for the patient. There's 2 streams in the model, a self-managed stream, which we would anticipate the vast majority of consumers would use. The vast majority of people are treated in the community and are able to manage their own care with a little bit of support and guidance. And then there's the supported recovery stream, which are for people who have more significant and complex care needs. The model of care is actually allied health led because allied health, such as occupational therapy, physiotherapy, speech therapy, dietetics, tend to be the leaders when it comes to rehabilitation in the community, in the Australian healthcare system anyway. But it is inclusive of consumers, medicine, nursing, primary care. We need everybody to be working on this particular issue. And we set it up with the idea of there's 2 groups of patients. There are new cases and there will always be new cases. In terms of the new cases, while the WHO has set a standard at 3 months, we're wondering whether we could take people into this model of care at 1 month if they're still having significant symptoms. It doesn't make a lot of sense to wait until things are really bad to intervene. Early intervention is a good thing. But there's also all the people who have been infected since the start of the pandemic, sort of a big backlog of people that we also wanted to be able to cater for as part of our model of care. So this is a very big overview of the model of care. There's a lot of detail underneath the details I'm about to tell you about, which we're happy to share with you, but it will give you an overview. So for the patient, they enter the model with a comprehensive assessment. A really strong feature of the model is regular revisions and regular resetting of goals as people recover. And then they're in one of either of the 2 streams. In the supported recovery stream, they would receive intensive multidisciplinary care via community-based rehabilitation. And they also get a designated care coordinator whose sole job is to coordinate all the different aspects of care that they might need. Something that came out really strongly is that every case of long COVID is kind of unique in terms of the constellation of symptoms and issues people have. So a care coordinator was one of the main things that patients are saying they really want to have. And then on the other side, you've got the self-managed stream, which is more like a navigator service. It's really about completing the assessment and then pointing people in the right direction as to where they can go in the health and welfare sort of world to find what they need. Along the side is also evidence-informed and patient-centred stream. This will be running alongside all of the assessments and treatment that's offered. And the idea of the peer support groups, the community of practice, embedding research and governance structures is to make sure that the whole model of care continues to be patient-informed, patient-centred, and keeps on top of what is a really rapidly expanding body of evidence. The other feature of the discovery model of care is it is designed based around 7 patient-designed principles of best care. So overarching everything that's in the model of care are these principles of best care, and they're expressed in 2 different ways. Primarily, they're expressed in plain language, which is what our consumers are asking for. And then in the brackets, you can see down the left-hand side, kind of translated into professional language too, in recognition of the fact that we speak kind of two different languages sometimes in healthcare and as a patient. So the comprehensive assessment is designed to meet the first three of these principles, which is understanding the impact on everyday life, not jumping to conclusions and making sure that every other alternative diagnosis has been looked at, and tracking recovery. So there's some information there about the assessments. We do have a co-design prom, which we will be using as part of the model of care. We'd be looking at some standard quality of life measures as well, but there is flexibility within the comprehensive assessment to bring in other assessments that are specific to that person's needs. So it's not a standard set of assessments for everybody. It is negotiated. The outcome of the assessment is obviously shared decision making with the consumer about which stream they want to go into and is going to best meet their needs. So briefly, in the self-managed stream, we know that not everyone will need intensive follow-up, and our consumers were saying they just want a one-stop shop where they can go to and get all of the information they need about where they can go next, like a concierge service. So the majority of this we're looking at delivering online via a website where people can run through a self-assessment and then they'll get the local information of where they can go to for further assistance. But we live in a community that's very diverse and has a lot of disadvantage. So we are also going to have a hotline so that people can ring up and just speak to somebody. And that's also really important for the use of translation services, that people may not be able to access everything online anyway. So in this supported recovery stream, as I mentioned, it would be intensive rehabilitation, multidisciplinary rehabilitation, but the focus is really on short term. We really want to get in as early as possible and provide people with rehabilitation and then move them out of our service back into the community and primary care, which is where people live their lives. So it's not meant to be set up as a siloed, separate long COVID clinic. It's meant to make use of existing services and for people to be with us for a short-ish period of time and then move on to primary care. So one of the main things that came out in our research from consumers is we don't want to be at the hospital all the time, which is more than fair enough. And then just on the side, that evidence-informed and patient-centred area, we would, as part of the model of care, facilitate some peer support groups. So obviously we wouldn't be running those because they're peer support groups, but part of the model care is to support those in terms of providing venues, maybe some leadership training for peers who want to take on that role, providing guest speakers and things like that. We're also looking at providing peer support groups that are tailored. So we have a large Vietnamese community, for example. We might run a Vietnamese language support group. Women do have different needs in terms of long COVID because of caring responsibilities, things like that. And we also already have a peer support group running for ICU survivors, which have a different profile of recovery. The community of practice is essentially for the healthcare workers to make sure they're keeping on top of the huge amount of evidence that's coming out about long COVID. And it would be to support clinicians from all of the disciplines to keep on top of evidence, learn about new innovations that we might want to build into our model. So it's to keep it up to date. It's going to be incredibly important to embed research. There's so much that we don't know about long COVID, and running a model of care in this way is going to be a really good way of collecting the evidence that we need to improve what we provide to our patients. And it was something that the consumers really asked for. They really want to have cutting edge treatment. They want the best sort of treatment they can get to deal with their long COVID. So embedding research in everyday practice is a really efficient way of being able to give back to the evidence base as well. And finally, the governance. The model of care will have a steering committee, which includes consumers and representatives of other key stakeholders, so that we can keep on a track that is patient-centred and evidence-informed, and that it doesn't just become something that sits within Western Health and is run by healthcare workers exclusively. So in conclusion, the main points we'd like to emphasise about the model of care is that it's not an entirely new service. It's not a long COVID service. That's a separate silo. the range and the diversity of what people need with long COVID can already be handled by a lot of existing services, and it's just about coordinating between those rather than building something completely new from the ground up. Long COVID, very sadly, is a growing problem, and new variants are going to cause greater case numbers and reinfections, which we know do happen. So this model of care will pay for itself, essentially, by reducing and preventing future disability, particularly in our younger consumers who have more of their life still to live. And obviously long COVID is a really complex condition, and there's a huge range of presentations. So the discovery model has enough flex in it that it can actually meet people on an individual basis and give them tailored support, not just a generic package of care. And patients are the current experts in long COVID. We simply don't know enough to be able to say any of us are experts. So they've got to be core members of service development and delivery teams. Thank you very much.
In the model of care for those with long COVID. We'll have time for one question if there's any questions online or from the audience, in-person audience, I should say. Yes, we have one question over here.
Thanks, Danielle. I really, really enjoyed your presentation. I love the elements of not just how you approached it, but even the elements of the programme. And given that you were talking a lot about co-design, and it's the first of its kind to be co-designed with consumers, how did you, I work with people with acquired neurological conditions, so obviously their participation can vary quite greatly on the day, on any given week. How did you support patients with long COVID to be able to participate? Was there anything in particular that worked well for you? Sorry, I'm Valerie from Ireland, by the way.
Thanks, Valerie. I think we really were mindful of that. My professional background is as an occupational therapist, so we're all about inclusion and accessibility. So we gave people lots of different options to facilitate their participation. So there was workshops that people could come to, or they could also do the activities in the workshop online in their own time. We had phone calls with people, so we really sort of kept it quite flexible. And also we didn't set up an expectation that people had to come to every workshop or comment on everything as it was developed. We made it really clear from the start, if you're up to it and you feel able to, we'd love to have you involved, but if you want to take some time off or today's not your day, that's perfectly fine. So I think it's about building in that flexibility and not trying to lock people into something that they may or may not be able to commit to.
Thank you. I'm now happy to welcome Stephanie on to the virtual stage from the University Health Network. Over to you, Stephanie.
Thank you for allowing me to share experiences in the virtual pharmacy space in this important series. In this segment, what I would like to do is describe the integrated care model in complex chronic disease and how it was applied to address the increased risk of medication-related problems. I would also like to present the virtual pharmacy model and how it was implemented in nephrology clinics in Toronto, Canada, and highlight the key medication outcomes to demonstrate its feasibility in practice, and then finish off with discussing the key implications and significance of these results in using an integrated care model and future plans of other practices. Medication-related problems is quite burdensome, especially in complex chronic disease like kidney disease. They see multiple physicians and transition frequently between healthcare settings, and the consequences are high, and it is the top 5 leading cause of death in complex patients, and also burdensome in emergency department visits across Canada. In studies that we've seen in ambulatory care patients, adverse drug reactions actually occur in almost 50% of our patients as a result of miscommunications between patients and providers. But what we also know is that 30% of our patients don't even pick up their prescriptions, especially if it's new for them. And 1 in 5 Canadian households don't fill prescriptions due to the lack of drug insurance. So our team really set out to find new models of care in order to target this problem. And we know there's evidence to show in other disease states like COPD or surgery, where there has been improvements in lengths of stay, readmission rates, or hospitalizations, but there hasn't been any targeted models to address medication-related outcomes. But what we know is that these models of care is easily translatable to address the root causes of medication-related problems, such as coordinated care and collaborative teams. This model really highlights the key framework of what the traditional system compared to what is the proposed integrated virtual care model. And in this comparison, what we're trying to show is in the traditional brick and mortar model, this is quite linear, but yet it is siloed and fragmented. In a proposed integrated care model, which targets medication-related outcomes, it is circular and more coordinated, but yet it is seamless and collaborative. In the virtual pharmacy model, it was really guided when it was founded and implemented on core principles based on the one principle. So at first, the guiding principle of one team was really the focus. All clinicians, including the patient, works as one collaborative team, and it is aimed at the same goal and with shared accountability. So we co-developed the process, including forms and activities, targeting specifically the burden of medication issues. This shared accountability between all members means that our roles are well defined and the responsibility of each member, including the patient, is discussed up front. There is also one record and documentation tool between all the members. The prescription form was key in this particular process, which I will show you later. And in this documentation, the information was redesigned in order to standardize it, and it is shared between all the members. Thirdly, there is one contact information that is used by physicians and pharmacists, but also a contact email and phone number between the patients and the providers. Often patients will complain that they cannot communicate their problems related to medications to a provider because they don't even know how to contact their provider. So often they fall through the cracks and stop taking their medications just because of this lack of contact information. So by providing them with this key contact, we hope to address this gap. Finally, we standardized the practice by implementing evidence-based pathways by using a standardized protocol for target drugs. So we only picked key high-risk drugs when we implemented this pathway, and it is supported by best practice and clinical procedures and protocols. This was agreed upon by the interdisciplinary team with the medication outcomes targets in mind. Then finally, the virtual care model was implemented as the backbone of this framework. We leverage pre-existing digital health tools such as email, electronic fax, digital prescription pads, and also digital signatures in order to make sure that we facilitate digital health for implementing this model of care. These are the details of what the virtual pharmacy pathway looks like. It starts with the prescription being initiated for target drugs. The pharmacist then receives a digital prescription by eFax for the various sites or various patients that were referred into the program. The prescription is then confirmed by the pharmacist, where they scan for initial problems, and anything that is seen then is then brought back to the clinical team and as they confirm receipt. So everything is delivered digitally without any paper prescriptions. Then there is a baseline pharmacy review where the pharmacist will do a medication history with the patient over phone or over video. They provide initial medication education. They also review any reimbursement investigation, meaning finding out if they have drug insurance to pay for the medications, any type of assistance that is required. Then they set up a monitoring plan and a follow-up with the patient, where they agree upon on what the patient should watch out for when they start a new medication, what they're responsible to report back, and who to report it back to, and they set out a schedule for the patient. Then the drug is delivered within 1 to 2 days directly to the patient's home, so the patient does not have to go to visit a pharmacy. There is then a first set of monitoring that is done by the pharmacist 1 week later to follow up on if the patient is taking the drug properly or if they even started the drug at all, to look for any side effects when the patient started, and if there's any initial clinical change. Then the pharmacist connects and collaborates with the physician team to give them a status report on the patient, and if anything is going wrong, that is documented and shared with the entire team. The second follow-up and third follow-up calls are then implemented 1 month and 3 months later after the start date. Again, to check on if the patient is taking the drug and taking it appropriately, any type of side effects, and also any clinical changes, whether the clinical change that they expected are actually occurring. This calendar highlights the idea of the overall time frame from start to finish, highlighting the specific time points on when and who connects with the patient and what type of information is relayed. With this standardized and coordinated schedule, the cracks and individual gaps are addressed, and each clinician, along with the patient, are held accountable on what to report, the status of the patient, to ensure the clinical outcomes are achieved and adverse events are reported in a timely manner. This is a sample of the redesigned prescription and referral form. And what was included in this new referral form and prescription is that there's now a full medication list that is included, and it is required so that it facilitates a review by the pharmacist. The indication or the reason why that medication is started is also included, so the pharmacist is well informed of what they're educating the patient about, along with a standardized monitoring plan so that the pharmacist, along with the patient, knows what to watch out for at what time points. Specific patient supports are also listed, including any type of adherence supports like blister packing a patient, language supports, or any type of drug insurance coverage that they need in this prescription pad. So all the specific actions that a patient needs are all written down in one form, so there's one documentation or communication tool. So we set out to implement this in the nephrology program here in Toronto at the University Health Network, and we partnered with McKesson Canada and their specialty pharmacy. We implemented this in 5 nephrology clinics, targeting complex diabetes patients and patients with oncological nephrology problems, including glomerulonephritis. And the target drugs included complex diabetes drugs, new medications that targeted cholesterol, and also other high-risk patients that were considered non-adherent to their treatment. The observation period was for a period of 12 months that started in February 1st of 2021 and lasted to about January 31st, 2022. And on average, there were about 60 patients that were enrolled during that time period, with an average median age of 72 years old, and most of them were on 10 to 15 medications, but an average of 10.5. So this was quite typical of our nephrology patients. When we looked at specific medication-related outcomes during this year, this is what we saw. So 36 out of the 60 patients had issues with reimbursement, meaning that they did not have the appropriate drug insurance to cover the cost of medications. So with the help of this program, 56% of those patients were able to access and navigate through these issues and acquire access to the medications. With respect to adherence, 91% of our patients were able to fill their medications within 2 days of receipt of the prescription. As you recall from our first slide, almost 30% of our patients don't even pick up their first prescriptions. So with this coordinated program, what we can hope to address is that we reduce the gap in the patient's adherence by supporting them and helping them pick up their medications. When we followed up with patients with baseline and follow-up calls, we had over 2,000 encounters between phone calls and emails between patients, pharmacists, and providers. Out of those 2,000 follow-up calls, we identified about 1 in 10 required an intervention in order to prevent harm or further harm to the patients. And this is about 208 issues that were identified. We further categorized these issues into their clinical significance, where almost half of them were mild, so there was no direct patient harm or discomfort that were identified, and no additional follow-up, but just monitoring provided or supports. Another half were moderate, where there's some acute or chronic complications that could have ensued if there was no intervention that could compromise patient's health. But with this intervention or coordinated program, we were able to avoid any type of acute or chronic problems further. Examples of these are drugs like an SGLT2 inhibitor, where it was started, but the patient had an increased risk of dehydration, so we had to temporarily stop it because they were going through chemotherapy. We did have certain cases where it was severe. So an intervention, just like the virtual pharmacy model, when it was implemented and there was a rigid follow-up, helped prevent any type of emergency visits, hospitalizations, or even death. An example of this is severe anaphylaxis reaction and rashes, where a patient started on a new drug like an SGLT2 again, or a patient was not taking their anticoagulant that was needed for their mechanical valve. So with a pharmacist and a physician collaboration, they were able to address this gap and prevent these severe harms to the patient. With respect to other outcomes with resources, even though there were over 2,000 calls made, on average, the average time that it took was 20 minutes. And when we actually looked at the formal cost of this, even though a formal cost analysis wasn't done, the average cost savings when we correlated it with financial impacts of these issues, which was about 200 Canadian dollars in downstream cost savings, which would quite be significant if the upfront cost investment is minimal. But again, we have to do a formal cost analysis in order to validate this. Then finally, with experience, what we want to show you anecdotally is that with our stakeholders, with patients, caregivers, and also clinicians, the benefits were high. These are some of the shared quotes from patients, caregivers, and prescribers of what they found when the virtual pharmacy integrated model was implemented. Patients and caregivers found that pharmacists were kept in the loop and are working closely with their clinical team, which was not yet found before. From the clinician's perspective, they found that the communication and standardized monitoring was seen as a resource-efficient manner in order to address monitoring for the patient, in order for us to provide early intervention that can avert long-term medical issues. So in conclusion, in this short segment, what I hope that I shared with you is that an integrated care model can target outcomes in medication safety in this high-risk patient, and it is feasible to implement. This integrated care model addresses key coordination gaps and also promotes collaboration in practice, and these gaps are needed to be addressed in order to address medication-related problems. But secondly, there has to be an intentional redesign in the process, but also to incorporate simple yet accessible digital health tools like email or e-fax in order to support this model. In future directions, the demands of COVID has necessitated us to implement these models to address integrated care, especially in the distribution of treatments such as Paxlovid in our region. So I hope to address any questions with the next segment. Thank you.
Did anyone have a question for Stephanie? Oh, we have a question here in the room. Just one moment.
Thank you for your presentation. Can I just ask, how did the patients find the new way and having an active role in terms of managing the medicines and the side effects? How receptive were they to the pharmacist being involved?
When we asked our first set of patients and also their caregivers, they're quite receptive of this new model. Firstly, because it was the first time when all players, including their retail pharmacists, was involved with the circle of care and being informed with medication targeted information, because they often found that it was a very disjointed system. So they really appreciate that. So they were now part of that team. But most importantly, they had very specific action items on the patient's point of view of what to do with their medications. So their voice was also heard with specific changes which often was a very anxious time in their treatments when they're starting new treatments. So it was very well received in that regard.
Thank you, Stephanie. Unfortunately, the Q&A through the chat isn't coming through currently, so I'll just open it up to the room to see if there's any questions from the audience, in person, I should say. No? Don't see any other questions in the room. Thank you so much, Stephanie, for your fascinating presentation. Maybe what we'll do, if the folks can hear me online, we do have an in-person presentation. Stuart, would it be okay if I pass it over to you and perhaps...
So this is in Dutch. It's actually in Australian, but I noticed walking here, even the dogs sound like they're barking in Danish, which is interesting. Must be a linguistic thing in dogs. Anyway, I'm here to talk about an area of Australia. If anyone's seen Crocodile Dundee, it'll be very similar to the sort of country that I'll be reflecting on here. I'd like to just commence by first of all, it's customary in Australia to acknowledge country. In the country I'm from is Niimba country, so they'd say Yama Garu Mia Kalpa Niimba. So welcome to Niimba country. Obviously we're in Denmark, but I'd like to pay my respects. I'd like to acknowledge the traditional owners on the country in which I live and work in Australia, and pay respects to their elders past, present and emerging, and extend that respect to the Danish people who are hosting our event here. So I'm just going to quickly run through a remote Australian context, looking to firm up place-based commissioning, things that we've all worked with as health, in health design and health delivery, health service delivery, describing an emerging alliance in my neck of the woods, what innovation has come out of that alliance, and what are some key reflections. So it's a big place. The spot I'm talking about in Australia, it's Western New South Wales. So I work with the New South Wales APAC Division of General Practice. My colleague, who can't be with me today, Bob Davis, he's the CEO of the Marama Aboriginal Health Corporation. And between us we cover this landscape of around 200,000 kilometres. So not a lot of people there. They actually say there's more cattle than people in our territory. But it's like, again, a bit like Denmark, there's more bikes than people. And you've got to stay out of the road of them too, I've learnt. But it's around 4 times the size of Denmark, to get a bit of an idea of geography. And it's categorised as very remote. So although as a crow flies, it's about 1,000 k's from Sydney or 1,000 k's from Brisbane, that's not far in Australian miles, but it is a very remote place, and it's categorised as that. So a lot of the features of that are typically what you'd expect to see in remote areas. It's defined by the Darling River, which is an inimitable feature of Australia, but also being a river, it has a collection of river towns that run right along it. So when we talk about remote health, despite all the investment, we still have incredible disparity for people who live in those regions. The colonialisation, which occurred hundreds of years ago, continues to play out its impacts on Aboriginal people and the relationships they have and their interactions with the health system. The social determinants are very powerful determinants of health in those regions, and even things such as climate change are really impacting on our populations now, challenging health providers to adapt and modify their approaches to health and wellbeing. And in many ways, when you consider Australia as a first world country and doesn't do too bad in the OECD standings, it's a health equity issue for a lot of people that live in those regions. They actually have a right to better health care than they currently get. And there's a powerful case for change. And as you can see, you can't see all the slide there, but in the town I live in, there's people really, their life expectancy is very different to someone who lives in northern Sydney. And we have this kind of phenomena, the inverse care rule, where the people that need it the most get it the least, and those that need it the least get it the most, and that those opportunities start very early in life. So there is a case for change for organisations working in that patch to disrupt the system and do things differently. We're not getting ahead of things the way we should be, and we have not only very high burdens of illness and potentially preventable hospitalisation, but they just seem to be deeply entrenched and not changing. For commissioners, and I've been one in one of the new primary health networks in Australia, forming one in Western Queensland actually, this health reform is attempting to try and deliver greater flexibility into the system, but like many things, and even in New Zealand we're seeing some changes at the moment, to the big organisations that are formed to deliver either the acute systems or the primary healthcare systems are moving further away from communities. So we find ourselves a population of around 38,000 people in a population of nearly 400,000. So it's like the tail on the end of the donkey or the beast, and it's very hard for communities to actually advocate and get a say in that environment. So when you're talking about commissioning, well, people and places matter. So where you live and why you live there needs to be a factor that comes into consideration when you're planning healthcare services. But unfortunately, they're often the last things that come into play. So scale means efficiency, cost savings, and it actually centralises a lot of decision making in those towns. And the subject matters experts aren't the commissioners; they're the communities themselves and organisations that live and work in those communities. And this is particularly the case for Aboriginal people, because cultural determinants are really, they're an extraordinary part of the configuring of health services. So as you can see here, Aboriginal people are connected to their wellbeing and care through their communities, through their country and through their organisations who are part of the community, and organisations such as Marama Health or others that are working across this catchment. They're all local community people working in these organisations, but in a bigger commissioning environment, it's often very difficult to actually get things configured in a way that allows you to get the best outcome for your communities. And so consequently, your ability to be responsive and change and really respond to those local issues often get lost as you get these more universal targets for improving health. And you lose the diversity of the health challenges that occur as you go across from a regional centre into really remote areas. So the alliancing occurred across three organisations. Two I've mentioned, the third, which is the Murray-Parky Regional Assembly. So that's an organisation that's been around for about 25 years, covers 16 local government areas. It's around 20 different Indigenous language groups, but they cover the whole spectrum of economic and social interests. It's largely advocacy. But these three groups have been around for quite some time. They've had a relationship where they work together, and so they've decided to take it to the next level. So there's been, over the last couple of years, some constitutional change to in the Outback Division, which is the one mainstream, we call it, this organisation that covers the whole community, where their constitutions changed to cross-pollinate their governance and membership, so that we now have a kind of an organisation that's able to broker and leverage from that trust. And as this matures, we will see more community-controlled organisations join it, but potentially more general practice networks and certainly other stakeholders such as local government. So some of the guiding principles here, obviously we want to improve health for Aboriginal people. That's core business for anyone that's in primary care in Australia, but it's particularly core business in remote areas where people are experiencing unacceptable levels of morbidity and mortality, where there's unacceptable levels of childhood vulnerability that just aren't. We're just not really hitting with the current approach that we're taking. But it also recognises if we can get it right for Aboriginal people in the way in which we put these services together, then other parts of the community all parts of the community will lift and benefit as well. So if we're able to support those that are the most vulnerable, then those other parts of the community will benefit. And look, it is about acknowledging that self-determination is actually a health intervention in itself. To be able to inform decisions around the health, the way services are configured, the way things are put together, is actually a determinant in itself. I'll get a wriggle on. I think, is that Danish for quick get a wriggle on? Righto. So, look, we heard some comments around leadership before, but this is just some feedback from some of the Indigenous leaders that were commenting on why we need to change. And it does all point to moving away from the transactional stuff and getting more transformational. So you can see there's emerging structures. The idea is to actually get more flexibility in funding and hunt as a pack, so start to look at collaborating early and look at new funding, not the existing pools of funding that are quite hard to change, but look to create new opportunities with new funding to do things differently. We sat down and navigated through a whole range of different value sets that we felt were really important to have as foundational to our relationship, and many of them there you can see are really kind of pointing towards that idea that if we do things differently, we hear people talking about it'll take generations to change the health gap, but if you do things differently, we can get change very rapidly. And it starts with actually leveraging from those often the personalities that are there at the table at the time to agree to come together and try and do things differently. So Anya was speaking a lot around leadership in there, and I think I agree with a lot of what Anya said, that at the end of the day, collaboration often comes from individuals, so it's knowing when you can activate that. So these are just some of the improvement domains. I'm not going to go through them all. You can see a lot of it is a little bit clunky in that we are running primary healthcare systems. We're wanting to do things more efficiently. We want to be able to recruit workforce into the bush. We want our systems to be the best they can be. And so it's about leveraging from who's doing it best and then sharing and scaling that. And also it is about the centrality of general practice, because that's the thing in which you manage your whole population. So the data is extremely important, but if you can't access it or you can't use it, then you don't really know what's going on. You can't rely on hospital data to tell you what the health of your population is or what are the issues that are impacting on them. One of the interesting things that emerged very quickly was a desire to do more research. So we saw 4 institutions come together with all the local governments of our region, and we're lobbying at the moment to establish a First Nations research collaborative, which really what it translates to is getting local communities in charge of their own research agenda, which is being supported through their organisations and the Alliance. We recently completed a very comprehensive housing environmental health plan for the 16 communities right across that region. And not surprisingly, that's just thrown up a whole range of other determinants which are now in the spotlight to try and respond to. And obviously during COVID, many of these river towns were impacted very early. It was interesting, but I was working as one of the leads on the response. And at one point we had 300 people that had COVID across those river communities, and there wasn't one non-Aboriginal person. That was almost uniquely spreading through Aboriginal families and communities. It was actually finding the most vulnerable people and infecting them. Again, it sort of brought into illustration the poor housing and the poor environmental health standards that persist, which you've kind of struggled to see why that's still happening. So the key reflections from where we're at with our alliance and where we hope to go, it really does come down to trust. And through those trusting relationships, look to disrupt and change, not wait for the next reform. We've got a new government. They've got a commitment to a treaty for Aboriginal people, which we hope will deliver lots of transformation and lots more cultural safety in the way in which we engage with Aboriginal people, but also how they can empower communities they live in. But it actually, trust gives you access to the data as well. And it means Aboriginal community-controlled organisations, the largely sovereign entities, share their data, and we learn about the things that are impacting on them. And that helps to bring the conversations and create the change and the innovation that flows from that. And also the other reflection would be that in an environment where there's no market, no one pays for anything, no one's got any money to pay, the most socially disadvantaged Aboriginal and non-Aboriginal, ageing non-Aboriginal populations. So in those settings, there's no point looking to the market to respond. You must go to the most vulnerable parts of it and configure your response around that. So that has to be the basis on which you build, and that starts with having a way to actually engage them. Supporting decolonisation approaches isn't just rolling off the tongue. It has to be, it's got to be central to what we do when we're shaping primary healthcare service. And it means understanding, reflecting and being conscious of a bias that systems and individuals will have when they engage and they deliver health services, whether individually or as whole organisations. And finally, culture counts. Culture is such a powerful determinant to health, so being able to find a way to configure your services, engage your communities and deliver healthcare in a way in which you can understand and embrace those the cultures of the regions you're working in will certainly lay a strong foundation to your effectiveness as a healthcare organisation. And that's all, folks.
Thank you so much, Stuart, for that excellent presentation and really, ending with those very powerful reflections. I think we can all relate or have seen that in the literature as well. Just looking through the app to see if there's questions coming in for Stuart, or I'll take a scan of the room here. Oh, yeah, we have a question in the room.
If it's about Crocodile Dundee, I've only seen it once, and I'm not related.
Hello, thank you for your presentation. My question is, how do the communities or the community members respond to co-design and co-creation, and also designing their own research agenda, as you mentioned?
Yeah, look, it's if I've got the question right, it's how's the community responding to the co-design? Yeah, the important thing there is they're not used to that process, which again it emphasises why it's important to use their institutions, their own Aboriginal health organisations. The other engagement, so if you say a community, these communities are quite contemporary, so they're Aboriginal, non-Aboriginal communities, the leadership appears to be coming through the community controlled organisations. So it is providing a new avenue to get issues of common concern up, and then across that scale you're actually finding that whilst there will be nuances in different communities, it's all really similar. So you get this very strong narrative that's coming through that's grassroots. So I think that that's going to be a very powerful way of informing how commissioning happens. And yeah, people are enjoying that experience, feel like they've got a voice. When you're just a single country town, it's hard, but when you're part of an alliance, you seem to have a lot more horsepower. In terms of the research agenda, this is new. We've looked a lot of what's happening in Canada and their First Nations research there. And when research, obviously, in some cases, whole organisations are funded through research. Like literally millions of dollars come onto the table or come into communities that weren't there before through having a research agenda. The important thing here is a framework allows communities to look at who's doing the research, who's actually helping to do that research. So what's the capacity building component? So this framework will look at how do local people get involved in research, how can they participate in it, then importantly how do they get to implement this so it actually means something to their lives. So this really early days, but you might have seen the United Nations logo there. There's 16 United Nations training and research arms in the world, and one of them is at the University of Newcastle, and they're a part of our alliance at the moment. So when you're getting that sort of level of horsepower in, they work very much in developing countries, and it's interesting, our environments are a lot like developing countries. They need the same sort of interventions with the numeracy literacy and health literacy and digital literacy that's required. So that's nothing yet, but stay tuned, maybe 2 years. Okay.
So for the interest of time, we'll move on to the next presentation. So coming to us virtually, I'm pleased to welcome Vicki, Cloney, and Anne Wardlaw.
Hello, my name is Vicki Cloney. I'm the partnership facilitator with CVS Inverclyde, which is the third sector interface organization in Inverclyde.
Hello, my name is Anne Wardlaw and I'm the Alcohol and Drug Partnership Coordinator in Inverclyde.
We are from Inverclyde, a small local authority in the west of Scotland, and we would like to share some cross-sectoral work we've been doing to support our communities, which we have called the Resilience Network.
Just as a background, we started to look at Hard Edges Scotland report. Langkelly Chase commissioned Heriot-Watt University to undertake the research of the Hard Edges Scotland report. This was published in 2019. The central aim of this study was to establish a statistical profile of the extent, nature and overlap of severe and multiple disadvantage in Scotland, and to reflect service provider and service user perspectives to understand routes into severe and multiple disadvantage. The disadvantages included homelessness, offending and addictions, and also considered the impact of mental health and domestic abuse. In Inverclyde, there are far more people in the substance misuse category at 67.83% compared to the Scottish picture of 44.47%. In contrast, Inverclyde has far less homelessness at 4.28% compared to Scotland at 34.12%. Inverclyde has a higher percentage of people in the offending category at 27.89% compared to Scotland at 21.41%. When considering the disadvantages, Inverclyde category of substance misuse and offending is higher than the Scotland picture. The percentage of people experiencing all three severe and multiple disadvantages is slightly higher in Inverclyde as well. The routes into severe and multiple disadvantages are poverty, violence and trauma. This slide is a diagram of feedback from people with lived experience and frontline staff. They described a revolving door and being bounced around services, of there being missed opportunities and the path being messy. In contrast, this is a diagram of what people would like to see in Inverclyde. I want to point out the difference in language. The words are really important and they do matter. People spoke about growing hope and taking small steps of being accepted and the need for multidisciplinary working, particularly across mental health and substance recovery. People spoke about belonging to and within a community. We wanted to break down silo thinking and create a door that was open to everyone without any labels. At the time, we looked at the Resilience Donut as a strength-based tool. Hence, we called it the Resilience Network. We took the decision to create a common language, a language of hope and compassion. William White defines a recovery-orientated system of care as being a coordinated network of community-based services and supports that is person-centred and built on the strengths and resilience of individuals, families and communities. These are the areas of impact that people identified as being critical in a recovery journey, taking a holistic view. We recognise that for many people, we need to look at these as a whole picture, as they all impact one on another. However, applying the theoretical model of the Resilience Donut, we need to help people recognise their strengths, build on these, and this will have a positive impact on the other areas. Vicki will now say more about some of the work the Resilience Network has done.
A month after we launched the Resilience Network, the United Kingdom went into lockdown due to the COVID-19 pandemic. As Anne described earlier, Inverclyde has significant deprivation, generational unemployment, and issues with drugs. The undercurrent of these multiple disadvantages was still present, but on top of it was the uncertainty and challenges of a global pandemic. As a network, we recognized that our community needed resilience more than ever before. We use the Resilience Network to share public health information with partners and to coordinate the efforts of the third sector. The areas of impact became our work streams, enabling third sector organizations to share information and resources to maximize our impact. At times, we were meeting weekly, which helped us to identify need quickly. Some examples of that work include: we sourced and distributed hundreds of digital devices for school children. We worked together to identify where food was needed and then sourced and distributed the needed supplies. We sourced children's clothing, including school uniforms, for any family who needed that help. We have a Slack channel, which is similar to Facebook for business, that enables Resilience Network members to share documents, links, and even instant message each other. This allowed us to keep in contact between meetings. Also, this coordinated approach reduced duplication and improved partnership working with our statutory partners. The work fed into the local humanitarian aid center, and using that data, we were able to adapt quickly to meet the needs of the community. It showed that we really are better together. When developing the areas of impact, the network highlighted the role of spirituality in building resilience. This isn't necessarily about religion. It's that core part of you that makes you human and connects you with something bigger than yourself. In the spring of 2021, we created a podcast series that explored the themes of loss, hope, kindness, and belonging. Small groups of people, including faith-based leaders, a hospice counselor, a young carer, staff from our local compassionate community, and local volunteers, came together to have a conversation about each of these topics. These were completely unscripted and immensely powerful, demonstrating the strength of the human spirit and how interconnected we truly are. Together, we build resilient communities. The networks I facilitate on behalf of CBS Inverclyde are open to people from the third, public, and independent sectors. Everyone is welcome. As such, the Resilience Network is a space for collaboration, knowledge exchange, and partnership working. Each meeting has a different topic to give us an opportunity to learn together and from each other. The community is at the heart of all of these topics. Sometimes the topics discuss direct interactions with communities, such as strength-based conversations or collective leadership. Other times, the discussions involve support for staff, volunteers, or even whole organizations. It's all about allowing us to offer the best of ourselves to the people we serve. I've included a few examples of past topics on this slide. Inverclyde Health and Social Care Partnerships strategic plan includes a vision for an Inverclyde that is a caring and compassionate community working together to address inequalities and assist everyone to live active, healthy, and fulfilling lives. And a key action from this plan that we're leading on focuses around building on the strengths of our people and communities. Anne and I sit on a lot of the strategic program boards and committees in Inverclyde, and we've noticed that many of them are discussing the impact of stigma on the people who are using their services. Since August last year, all of the Resilience Network topics have included discussion questions relating to stigma to bring some of this work together. Whether the discussion is about refugees, people coming out of prison, or those utilizing food banks, stigma is always relevant. Also, late last autumn, Inverclyde Council hosted a virtual listening event during which the community highlighted that stigma is an ongoing issue in Inverclyde. Anne and I knew something more needed to be done. All of this fed into an online event to challenge stigma, hosted by the Resilience Network this past February. In the lead up to the event, a short life working group was formed from Resilience Network partners representing different specialties such as mental health, community justice, LGBTQI+, etc. Together, we looked at literature and local and national policies to develop discussion questions for the event. The event itself brought together professionals and service providers from all sectors and members of the community, many of whom have lived or living experience. We came together as equals to understand what lies at the core of stigma and how we can work collaboratively to reduce the negative influence stigma has on the opportunities and inequalities in Inverclyde. The Chief Officer of Inverclyde Council delivered the opening address, sharing her inspiring vision of an Inverclyde free from stigma. A lecturer from Glasgow Caledonia University spoke about labels, noting that people in positions of power and privilege get to create the labels for others. We discussed that babies, although new to the world, are impacted by the situations and stigma into which they are born. This was followed by 3 videos of local people with experience of stigma, which now sit on the CBS Inverclyde YouTube page. Anne led us in a discussion about the power of language and the impact of showing kindness through the words that you use. That discussion created the graphic you can see on the screen, with participants sharing the words they themselves would like to hear. This influenced the afternoon session, where the Short Life Working Group members facilitated the discussions. Ultimately, this is where the event found its real impact, with an afternoon of hard-hitting discussion, much of which became led by members of the community who are actively in recovery from addictive behaviors or feeling the effects of stigma in their own experiences. This event is just the beginning of the work on stigma, with follow-up sessions planned throughout 2022. Through the challenge stigma work, we have welcomed the community into the Resilience Network and will work side by side with them to make a change in Inverclyde. The Resilience Network is all about partnerships, and on the screen you can see a handful of the organizations who make up this network. We're about 100 members strong, and we'll use our collective strength to build resilience and foster hope across Inverclyde's communities. As former US Senator Barbara McCluskey said, each one of us can make a difference. Together, we make change. Thank you so much for having us. Our contact details are on the screen, and we would welcome any questions, comments, or feedback. Thank you.
Thank you so much, Anne, and thank you for that excellent presentation and a really important conversation on community resilience and the role that resilience networks can play in improving community health and well-being. Unfortunately, we're just a little tight for time and we have 2 more presentations, so we're going to ensure that they have their time to present, and then if there's time at the end, we'll come back. I encourage participants to put questions through the app, or you can engage directly with the presenters through the app as well. So next up, I'm pleased to introduce Philiz Goat. So Philiz, over to you.
Hi, everyone, and thank you for joining us here today. We are thrilled to be speaking to you from Toronto at the ICIC 2022 conference in Denmark. Technology can be amazing. Today, we will be talking about what are the barriers to co-design and what would integrated care look like. My name is Carole Alloway, and I was a caregiver for my husband for 13 years until he passed away last October. In 2010, he had an operation for an ankle replacement, and because of a recurring undiagnosed infection, Phil ended up having 10 surgeries over 7 years and developing congestive heart failure. Because no one took our questions seriously about why the infection kept recurring or offered us other options, and because home care was spotty and unreliable, I took over as advocate, nurse, driver, appointment juggler, and much more. After 5 years, I was diagnosed with depression. A specialist can only know one tiny piece of a patient. The patient is the expert, followed closely by their family caregiver, because they see the whole person. If care had been integrated, Bill would only have needed 3 surgeries. I wouldn't be a customer of the healthcare system, and we would have had 6 years of our retirement free from hospitals. Imagine the cost savings to the healthcare system. Philiz?
Hello, my name is Philiz, and I am a certified registered oncology nurse who cares for patients with breast cancer. More recently, I am a patient from an accident that caused a traumatic brain injury. I got involved with the first North American Conference in Integrated Care in 2021 because the patient experience throughout my healing journey and my experience as a registered nurse. When I care for my patients, I try to provide the best quality patient care possible. But when I was a patient, I noticed gaps in the system that I fell into the cracks. The healthcare system relies heavily on the patient to advocate for themselves. But what happens if the patient is unable due to a brain injury and does not have any caregivers to advocate for them? That is just one reason that I became a patient advocate. And in this presentation, you will hear about ways a healthcare system can decrease the chances of a patient falling through the cracks. Today, we will share with you the names of the participants, the results of the discussion session held at the first North American Conference in Integrated Care in Toronto in October 2021 on this topic, and some information about NUCA. Lastly, we will open the session up for any questions. The participants at the discussion session for what barriers of co-design and what truly integrated care looks like were Karen McIntyre. She is the Senior Director of Human Resources at the South Central Foundation. We had Dr. Steve Tierney, the Senior Medical Director of Quality Improvement at South Central Foundation. Diane Furhiller is the co-lead of the Family and Child Health Initiative in the Peel region. Leslie Ashley is a patient and the lead in engagement and design at Trillium Health Partners. Francine Buchanan is the research patient and family coordinator at Sick Kids Hospital in Toronto. And of course, we have Carole Alloway, who is my co-presenter.
When looking to integrate care, it is critical to get perspectives from all your customers, patients, caregivers, families, and community, but also your admin staff, nurses, nurse practitioners, janitors, cafeteria staff, family physicians, specialists, social workers, police services, and even other healthcare facilities that you deal with. When you reach out to your community, are you sharing the space, but not the power? Because that's tokenism. Everyone at the table should have an equal voice and an equal vote. Hi, so what's wrong with you? That's the usual opening sentence from the doctor to the patient. But it is the patient's perspective of what wellness means to them that is important, and it is different for every patient. Being curious is the doctor's best friend. By asking the patient, what is important to you, can be a better approach to getting the conversation started. Include the patient's designated family caregiver in the conversation. They are a wealth of information that you need to make a proper diagnosis and create a wellness plan. Just like getting blood and X-ray results, caregivers can give you the history, preferences, and their insights that they have learned over years of knowing the patient. Treating the whole patient is the key. To treat the entire person means looking at their social connections, housing, food, and financial security. Wellness is comprised of prevention and resilience. Patients and their caregivers need the tools to prevent disease and injury, and looking at the whole person is the only way to accomplish that. Patients and their loved ones need to trust the healthcare system. Therefore, medical professionals must hold themselves and others accountable. These are learning opportunities. If you are a teaching hospital, are you also a learning hospital? After my husband's and my experiences with the healthcare system, I no longer trusted any of his healthcare practitioners, and I took it upon myself to do my own research and take on some of the home care duties in order for him to get the care he deserved. If I had been recognized as part of the healthcare team and my questions had been answered, my husband would only have needed 3 surgeries and not 10, and I wouldn't be a patient of the healthcare system. Think of the savings, not only healthcare dollars, but to our quality of life. We have seen the results of the family doctor having one system, specialists having another, and hospitals yet another, with no way to communicate. None of these systems are controlled by the patient. It's not pretty, and it can cause harm to the patient. We need one integrated system that the patient owns and allows others to access. The system must be up to date and accessible at any time by all who are given access. There should also be a way for the patient to read and correct information. We can do this if we work together. When looking at the patient, do you see a heart condition or do you see the person? Do you see an ankle replacement or do you see the whole person? We must care more about the person than the illness.
NUCA is part of South Central Foundation's relationship-based and customer-owned system that improves outcomes and reduces costs. NUCA means strong, giant structures and living things. South Central Foundation is Alaska Native-owned, nonprofit healthcare organization that serves nearly 65,000 Alaska Native and American Indian people living in Anchorage, Manitousca, Sustina, Borough, and 55 rural villages. The South Central Foundation went from employing 100 employees to over 2,500 people in more than 80 programs. It also went from an annual operating budget of $3 million to $478 million US dollars. The Alaska Native Medical Center opened its doors in May 1997. Since then, the South Central Foundation instituted significant philosophical changes and other changes in the design and administration of their programs. Some programs include audiology, child and family developmental services, elder programs, dental services, traditional healing clinics, and much more. The South Central Foundation instituted a total system-wide transformation of care that increased the quality and adaptivity of programs and, more importantly, the accountability of providers and customers alike. Alaska Native people are in charge of designing and delivering healthcare, and the focus on relationships extend beyond healthcare delivery. To ensure the whole system transformation, each system was redesigned to ingrain an organization-wide focus on relationship building and shared decision-making. The redesign included workforce development, compliance, human resources, and finance. The result is 97% of their customers are satisfied with their care. 95% of their employees are satisfied with what they do for work. And there was a 44% decrease in ER visits between 2000 and 2004. The NUCA system of care slowed healthcare spending by improving the population's overall health. Between 2004 to 2009, the annual per capita spending on hospital services grew by only 7%, while primary care spending remained below the national index. This comes to the end of our presentation. Are there any questions for Carole or myself?
Carole and Philiz, for your excellent presentation, really emphasizing that paradigm shift from what matters or what's the matter with you to what matters to you. We're just going to get going with the last presentation for today. And again, if there's time at the end, we'll do some questions. So the final presentation today, so sorry, I just had it up, is from Myriam Fournier-Tombs. Over to you.
For the opportunity to speak with you all today. My name is Myriam Fournier-Tombs, and I am Strategic Advisor and Lead of the Partnership Network at the Center of Excellence on Partnership with Patients and the Public. The CPPP is housed at the Research Center of the University of Montreal Hospital, also known as the CHUM, and is situated on the traditional territory of the Ganyan-Gehaga peoples. The goal of my presentation today is to share some of the work that we have conducted at the CPPP in collaboration with a number of actors in Quebec's health ecosystem to mobilize and integrate the experiential-based knowledge and skills of patients across many areas of health in medical education, health research, organization of care, and beyond the healthcare system directly in the community. In the following slides, I hope to take you on a short journey and share with you how each of these areas has evolved, as well as highlight some of the key turning points that fueled the growth of the patient partnership movement across Quebec. But before diving in, I want to give you a bit of context by quickly presenting the CPPP. So the center is an organization that was co-founded and co-developed by a patient called Vincent Dumez, and we also have patient partners fully embedded in our team. This is because the key focus of our work and what makes the CPPP unique is that we mobilize the experiential-based knowledge and skills of patients as experts of living with illness and as experts of using and navigating health and social services. This expertise complements the expertise of healthcare professionals, which are experts of health and disease. So in light of this, the mission of our center is to make partnering with patients and the public a science, a practice, a culture, and a new standard for improving the health of all and the health experience of each. Like many of you, the core of our work is to promote a new model for care where patients and their families are recognized as full actors within their own healthcare teams, and as such, they should also be partners of our healthcare systems and organizations. So we try in everything that we do to promote this complementarity of expertise between healthcare professionals and other actors in the healthcare systems and the expertise of patients, family members, and citizens with lived experience. So we do this through 4 major objectives. So first, supporting the strategic development and implementation of patient and public partnerships at the micro, meso, and macro levels, so operational, tactical, and governance. We demonstrate how partnering with patients and the public is a major lever for improving and transforming our healthcare systems. We serve as a center for reflection, capacity building, knowledge sharing, and transfer to contribute to the social integration of innovations on partnership with patients and the public. And finally, we develop and support the practice and science of partnership, or in other words, doing research on patient partnerships and in partnership with patients. So now our journey begins with a systems view of the 4 key areas of transformation, mobilizing patient partnerships. So as I mentioned before, education, research, organization of care and services, and the community. So for us, it all started in 2010. In the area of education, when the first patient partnership office was created at the University of Montreal's Faculty of Medicine. The creation of this office was a sort of institutional anchor for patient partnership, which enabled 2 key things to happen. First, the concept of patients as partners in their own care was embedded into the concept of interprofessional collaboration, which was being implemented in the faculty at the time. So this opportunistic approach is a recurring theme that you will see throughout our work, and is, in my opinion, one of the key success factors to fueling the cultural transformation of patient partnership. Second, and in parallel to the creation of the partnership office, the patient partners in our team co-developed with healthcare professionals a competency framework that further defined why and how patients are partners in their own care and what competencies they have and develop as partners in care. So since then, the involvement of patients as partners in medical education has scaled exponentially, and patients are involved in co-developing curriculum content in the Faculty of Medicine and across the 14 health science programs of the university. They participate on the admissions committee for new medical students. They help to co-evaluate medical trainees during their clinical exams, and they are co-chairs on key educational program committees. So furthermore, the Patient Partnership Office is seen within the Faculty of Medicine as a mobilizer of solutions, and together with the Collège des Médecins du Québec, the Royal College of Physicians and Surgeons of Canada, and the Federation of Medical Specialists of Quebec are contributing to transforming the future of medical education and training of healthcare professionals by including the experience and expertise of patients. And today, over 4,500 students per year are introduced to the concept of being a partner in care with their patients and have patients as co-teachers in their program. So patients are changing the way we teach and train from we care for to we care with. Next, we move to health research, where in Canada, patient engagement in research has been significantly moved forward by the development of a national strategy by the Canadian Institutes for Health Research, known as CIHR, which supported the development of institutional infrastructures in each province called SPORE support units. These units enabled the anchoring of patient engagement in research by supporting researchers and research organizations to engage patients in their work, not as research subjects, but as an integral member of their research team. It has also been very critical for the center to be affiliated with 2 publicly funded research chairs, which are uniquely focused on patient, public, and community engagement and study the impact of patient engagement. So these are chaired by Dr. Antoine Boivin and Dr. Marie-Pascale Paumet, who are also two of our scientific co-directors. The work of these chairs and more broadly research on patient engagement is essential to advancing this emerging field. And a key factor, success factor in building out the field of patient engagement, which a few years ago wasn't even acknowledged as its own field of research, is being comfortable navigating and evolving in these gray zones and allowing a necessary tension, both human and organizational, to persist. So today, patients are sitting on key scientific committees. They're supporting reflections on evaluating research and innovation at the highest level, and they're helping to define, for example, the utilization of new technologies within hospitals and at the Ministry of Health level. So most importantly, though, these structures have helped to develop communities of practice for patient and family partners that are growing across all 4 major university networks in Quebec. So in the context of this growth, capacity building and more broadly community building is a major success factor in scaling and sustaining this culture change. So patients are really changing the way we ask questions, we study, and we create new knowledge about what is important in health. In the area of organization of healthcare, there were 2 major healthcare reforms in Quebec, which were seized as opportunities to push for, test, and implement the involvement of patients as actors of healthcare transformation. So during the first reform in 2013, there was a push to adopt a lean management methodology in the healthcare system. And this allowed us to implement the concept of patient involvement in quality improvement committees. And again, we see here an opportunistic strategy to integrate patient partnership within pre-existing structures in the health system. The second major reform occurred in 2015, and due to strong patient voices, each of the 22 regional health centers, here known as CIS and SUS, were mandated to have a patient or user partnership office, and this was embedded in their new organograms in each of these centers. So following this in 2018, the ministry, in collaboration with many patient partners and experts in partnership, developed a framework document to help our ecosystem understand and implement partnership with users and their families, and supported this much needed capacity building across Quebec. So here it's important to highlight that co-design is really the cornerstone of our work, and it is truly achieved by the recognition of patients' complementary expertise. So I can't highlight enough how the creation of the patient partnership offices has made a change for involving patients across the healthcare system, and specifically in the area of the organization of healthcare. Under the creation of these regional offices, there was an incredible initiative which was undertaken under the leadership of Dr. Marie-Pascale Paumet, which was the development of a community of practice of staff and patient partners of all of the patient partnership offices across Quebec, which now meet 3 times a year. We have seen a marked progression in the level of expertise since the creation of this community of practice. The growing experience of patient partners also was marked. And in general, the interest to involve patients more across the Quebec's entire health system was also noted. Patients help us redefine what quality, safety, performance, and care look like, and are really helping us to transform ideas of what care is and should be. So lastly, while we all work intensely within the healthcare system to transform and hopefully improve it, it's crucial that we extend our work and really go beyond the system to support a social and societal change to help all public members to be partners in their own care. We have very modestly begun to reflect and experiment on bringing the concept of partnership in care directly to the public. And we have done so by creating, for example, piloting a small program to develop a curriculum and activities within a high school for partnership in care, as well as pilot tested a training program for caregivers in hospital setting, really looking at what are caregiver competencies as partners in care and how these can be further supported and developed. We also have regular activities for our patient partners through what we call the Patient Academy to help patient partners to further develop and mobilize their experiential-based knowledge and partner in different areas of the system, such as in digital health, artificial intelligence, for example, which are not always the simplest areas to throw patients into. In the upcoming years, our hope is that we will be able to further the concept of patient knowledge, looking more specifically at different categories of knowledge that patients develop through living with illness. And we all know that empowering each and every one of us as partners in our own care is the future of health. So as our journey comes to an end, I would like to mention the most important part of our work, which is the incredible human relationship, which are really at the core of who we are, what we do, and how we do it. At the CPPP, we like to say that we're kind of a living lab of partnership because half of our team are patients, and the expertise we build is based on their experiences, which includes in a couple of years, so 6 years, 3 new diagnoses of chronic diseases, 4 hospitalizations, 3 major surgeries, including a heart transplant, 6 medical absences. And so it's not always easy. And these are definitely challenging situations that we experience as a team and individually. But it's really these human experiences that highlight why co-building with patients is fundamental to transform health and humanize our systems for all of us, because it's these profoundly human experiences which allow us all to stay connected to a deeper purpose when engaging in healthcare transformation. And so this is our dear executive co-director, Carole Wong's favorite picture of our team, which I actually want to thank for the big role that she played in piecing together the history of the center and the patient partnership movement in Quebec. So thank you, Carole. And this picture was taken at our international summit in 2019. And I love this picture as well because it really depicts our team. We're a bit chaotic and never missing a chance to discuss and debate even during a picture, but we're always willing to try together. So thank you for your time.
Were you able to hear me, Myriam? No, I'm so sorry. I was just saying that we are just on time, but we did have one quick question for you before we go, which is, who is the lead for the Patient Partnership Office? Are they a patient or clinical or admin person?
So the lead, there's always a co-leadership at the Patient Partnership Office. So at the University of Montreal, it's Vincent Dumez, and as well at the Center of Excellence, Vincent Dumez. So we always encourage like a co-leadership. And there's like a managerial kind of leadership and then a patient lead. But for the patient partnership offices across the province, I'm not sure if that model is replicated, but in any case, when we work and when we encourage, when we kind of coach teams across Quebec, that's always the model that we propose or encourage.
Thank you. Thank you so much. A huge round of applause for all the presenters today, in person and virtual. And thank you all for joining the session today. Have a great rest of the conference.